the case. That you have to understand. Right. So this is the take-home message. So we are trying to give minimum fluid in febrile phase. These phases, of course, we are going to elaborate in a minute. Just sufficient fluid in critical phase. Again, minimum fluid in recovery phase, but don't give unnecessary boluses. So these are the summary in this lecture. So by doing this, we can treat shock and we can avoid organ damage because we are treating shock. And we can prevent fluid overload also because we are giving just sufficient fluid to maintain the hemodynamics. So we are treating shock, we are preventing fluid overload. So these are the main causes of death in dengue. So if you can prevent these two, definitely we can prevent the death. And remember, all of you know about the Gaussian distribution or the normal distribution. So dengue also will behave or distribute normally. So you will have there are a lot of patients who are in the middle. So basically about 68%. So you can manage with maintenance plus 5% fluid, guidelines, district hospital, and you will have another small proportion. Sometimes even with maintenance fluid you can manage, but remember there's another proportion, another part of it. You need huge amount of fluid, interventions, thinking beyond guidelines, tertiary care hospitals, and sometimes needing ICU. So this is very, very important. So how can you diagnose dengue early? That is very important because if you diagnose dengue early, the management is very simple. You can treat very easy. But if you don't diagnose dengue early, the management will be difficult. So the other important thing is, when you are diagnosing a disease, but usually what you are doing is history, examination, and investigation. But in dengue, history and examination will not give you any clue sometimes. So depends on the investigation. The most important investigation here is full blood count. So it's a very simple full blood count, but you have to do it in day 3. That means after 48 hours of fever, if you are doing a full blood count, if the full blood count shows white cell count less than 5,000, platelet count less than 150,000, unless proven otherwise, that is dengue in Sri Lanka. So I'm emphasizing day 3 full blood count, white cell count less than 5,000, platelet count less than 150,000, that is dengue in Sri Lanka. And these are the criteria for admissions in pediatrics. So if your patient is having platelets less than 150,000, you have to admit. So what about this NS1 antigen? A lot of emphasis, a lot of people are doing it. So now because of this COVID, you are discussing about the antigens. So antigen is a part of the virus. So NS1 is a non-structural protein 1. So it's a part of the virus. So we are trying to detect this with this test. So obviously this virus particle should be there for you to detect this test to be positive. So NS1 will be positive on day 1 to day 3, obviously, because when the patient is developing antibodies, so this antigen will disappear. So it should be done early. So if you are doing it, best results, best positive rate will be on day 1. So that is important. So this is antigen. So now think, if you are getting antigen, your body will produce antibodies. First IgM, then IgG. So this is the first attack. So first thing, you are getting antigen, your body will produce antibodies. Then when the disease is cured, because most of the time, first attack of dengue is like any other viral infection, no big deal. So they will recover. But if the child develops the attack second time, now this antigen is coming to the body, but you have the memory cells. So body will produce IgG antibodies in large amount. We call it antibody surge. So if you're having antibody surge, then this antigen will be disappearing from your body very quickly. So what I'm trying to say is, in secondary dengue, sometimes this antigen will be not in the body, even day 1, day 2, because this is very quickly happening. So antibodies will come and neutralizing these antigens. So your antigen test will be negative. So that's the theory. So I am not going to go into detail. So to know better than me about this antigen antibody. So this is important. NS1 in primary and secondary dengue. Primary dengue, NS1 positive rate is more than 90%. Now you can understand that. And but in secondary dengue, the NS1 positive rate is only 55 to 70%. So it's about 50%. So that means 50% will be positive, 50% will be negative. So it is very important if you are doing this antigen to remember this. You may miss 50% of secondary dengue if you are doing antigen. So be careful, because in Sri Lanka, what matters is the secondary dengue. You should not miss secondary dengue because all the problems are with secondary dengue. So remember, if you are doing antigen, that's okay. Remember the problems with antigen. Right. So dengue and dengue fever versus dengue hemorrhagic fever. Again, this hemorrhagic nomenclature in this dengue hemorrhagic fever is a misnomer. So you don't have to have hemorrhages to say it's a dengue hemorrhagic fever. So difference between leak. If you have plasma leak, that is DHF. If you don't have plasma leak, that is DF. So difference between DF and DHF is plasma leakage. Then the clinical course of dengue. So we will have three phases: febrile, critical, and recovery phases. Febrile phase means it's like any other viral infection. We'll have high fever for 2 to 7 days, facial flushing, for positive tourniquet test, hemorrhaging diathesis, enlarged liver. So they are there. Then you have critical phase. This is usually after 3 to 5 days of fever, rapid drop of temperature, increased capillary leak. Usually that lasts for about 24 to 48 hours. You will have abdominal pain, hematocrit will go up, platelets are going down, liver derangement, clotting profile problems, bleeding, hyponatremia, hypoalbuminemia, respiratory failure, withdrawal. You name all the problems in dengue are in this critical phase. Then you have the recovery phase. Don't worry, so we can elaborate on these things. So recovery phase, itchy recovery rash, bradycardia, platelets are going up, hematocrit becoming normal. So basically, the child is improving. So you can see the problem is critical phase. We are not worried about the febrile phase. We are not worried about the recovery phase. The problem is in the critical phase. So in dengue fever or DF, we have febrile phase and recovery phase, but no red area, no critical phase. But in DHF, we have febrile, critical, and recovery phases. Since we have a critical phase, that is the problem. This red area is the problem, right? So who are the high-risk patients? Infants, obese patients, prolonged shock, bleeding, encephalopathy, underlying diseases, pregnancy are high risk. So if your patient belongs to this, so obviously you will have infants less than 1 year, obese, prolonged shock, bleeding, encephalopathy, underlying diseases. So if they are there, those are high risk patients. So you have to be more vigilant about managing these patients. So be careful. These are the problematic patients. Then this is about the prolonged shock. This slide is from Thailand, but they say if you have more than 10 hours untreated shock, death is inevitable. That doesn't mean after 10 hours child is going to die. They will develop liver failure, renal failure, multi-organ dysfunction, and die after about 2 weeks or 1 month in ICU. So that the beginning is there. Beginning is there. So more than 10 hours untreated death, untreated the shock, death is inevitable. More than 4 hours untreated with liver failure, prognosis is 50%. With liver plus renal failure, prognosis is 10%. With 3 organ failures plus respiratory failure, prognosis is a miracle. So that is very, very important. That's why we have to detect shock, if possible to prevent shock, to avoid organ dysfunction and death. I know you may have told about the shock. Shock is inadequate tissue perfusion. So earliest sign of shock is prolonged capillary refilling time. If your capillary refilling time is more than 5 seconds, that means it's a shock. So if you keep this level, so that is what we want. If it is capillary refilling time is prolonged, you need to treat that. Right. So then major causes of death. So as I told you, if you give more fluid, the child will end up with fluid overload. But if you give less fluid, the child will end up with prolonged shock. So both are bad. Don't give more fluid. don't give less fluid, because both are bad. Fluid overload as well as prolonged shock can cause death. So what you have to do is sufficient fluid in critical phase. If you give sufficient fluid in critical phase, you are not causing fluid overload, you are not causing prolonged shock. So obviously you should be prevent death. So that's the key. So if I want to prevent death in dengue, you should not give more fluid, you should not give less fluid. Right. So what about the fluid management? So here the principles are minimum fluid in febrile phase, minimum fluid in recovery phase, but just sufficient fluid in critical phase. So that's the key. The danger is in the critical phase. You should not give more fluid, you should not give less fluid in critical phase. So how can I do that? So theory is very simple, but how can I do that? So these are the 4 things that you have to do to achieve this goal. So identify the beginning of the leak, predict the end, try to give only maintenance plus 5% fluid, and match the leak. So these are the 4 things that you have to do. So we'll go one by one. So identify the beginning of the leak. So this is how we identify. If your platelets are less than 100,000, if your PCV is rising towards 20%, if you have pleural effusions, ascites, low albumin, low cholesterol. So if you have these 6 things, that means the child is in critical phase. In other words, the child has developed leaking. So these are the features of leaking. Platelets less than 100,000, PCV is rising towards 20%, pleural effusion, ascites, low albumin, low cholesterol. So those are the features of fluid leaking. Then this is very important graph. So concentrate about this. So this is my febrile phase. This is my critical phase. This is my recovery phase. So first look at the platelets. So during the febrile phase, platelets are dropping. So when the platelets are going below 100,000, that means patient is entering in the critical phase. So even in critical phase, platelets are dropping, and during the recovery phase, platelets are rising. So this is the platelet graph. Then look at the white cell count graph. So white cells initially dropping, but when the patient is entering into critical phase, white cells are rising. So if you have serial white cell count, you can say platelets are dropping, white cell count initially dropping, but now rising. So if you can detect this point, you can easily detect the entry into the critical phase. So that's the entry into the critical phase. Right, sorry about that. So anyway, so that's the important point. So if you can detect this platelet dropping, but the white cell count is rising, so that's the point of entry into the critical phase. So if you can detect this, so that's very important. So as pediatricians, we are so happy because now the parents are so worried. So they are doing these white cell counts very frequently, and so you are having frequent white cell counts. Sometimes they are doing BD, sometimes even 670. So you have in front of you various counts are there. So you have to just elaborate on these things, critically evaluate these counts. So you can detect this platelets dropping, but the white cell count is rising. So that's the point of entry into the critical phase. That's very important. Right. Then, so this is the second step. So predict the end. So this is the natural history. You are starting the leaking here. Gradually leak will go up. So maximum leak is around 24 hours. Then leak will go down and leak will stop by 48 hours. You are starting leaking. maximum leak is around 24 hours. Up to that point, leak is increasing. Then leak will go down gradually, and the leak will stop by 48 hours. So we call this as a ascending limb, and we call this part as descending limb. So this is the maximum leak. So your starting leak, ascending limb, maximum leak is around 24 hours, where patient can develop shock. Then we have descending limb. Gradually, leak will go down and leak will stop by 48 hours. So this is the natural history of the disease. So now think, if a child is developing shock today at 12 noon, we know till tomorrow 12 noon, the patient is in ascending limb. So tomorrow 12 noon, we are expecting some problems. So you can develop shock, you can develop various problems tomorrow 12 noon. Then after tomorrow 12 noon, till day after tomorrow 12 noon, you are in the descending limb. So amount of fluid should gradually go down. So that's what the natural history says. So you can predict this. So when you are managing the dengue patient, this triangular shaped graph should be there in your mind when you are managing the patient. So then your management decisions will be very easy. Right. So then try to give only maintenance plus 5% fluids during this time. So again, this try is very important because sometimes we may fail. So as I told you initially, your aim is not to give minimum amount of fluid. Your aim should be maintain the hemodynamics so that you are avoiding organ damage. So that may be maintenance plus 5, maintenance plus 20%. So we don't know. So amount is depend on the patient's clinical condition. Right. So for do this to give only the maintenance plus 5% fluid, what you should do is calculate the fluid for ideal body weight in obese children, because we know that in children we are calculating fluid according to the body weight. So in obese children, you have to calculate for the ideal body weight rather than the real body weight. Then give only the amount needed to maintain hemodynamics, and frequent monitoring and adjusting fluid. And please don't give unnecessary boluses. So that is very important because we are talking about a leaking bucket. So if you fill this bucket very rapidly, you will have more and more leak. So then you have to manage the pleural effusions and ascites later. So if you are filling this bucket rapidly, so boluses should not be given unnecessarily. Then match the leak. So that's the very, very important thing. So if you are having leaking about 500 ml over 1 hour, if you are giving only 500 ml over 1 hour, that means basically you are matching the leak. So you are not causing fluid overload. You are not causing the fluid depletion, or you are not causing poor organ perfusion. So that's the key. If you can match the leak, you can win always. So how can you do that? So for that, you have to monitor these parameters. You are monitoring urine output, PCV, pulse volume, peripheral coldness, capillary refilling time, and blood pressure. 6 parameters are monitored because by monitoring only one parameter, you cannot get any idea. So don't go by one parameter. Monitor all these 6 parameters. So then you can have some idea about the intravascular volume. So if your urine output is less than 0.5 ml per kg power, your PCV is rising, the pulse volume is low, peripheral coldness is there, capillary refilling time is prolonged, and blood pressure is low, you know that the child's intravascular volume is not enough. So that's the key. But having said that, you may have done these things now. So you know about the PCV, you are pricking the child, taking blood to the capillary tube and put some clay on either side, and then you are putting in the machine. Sometimes half of the thing is machine will evaporate and you are having some number at the end. So what do you mean by this? I don't know. Pulse volume, as an intensivist, I will come and say, okay, pulse volume is adequate, but for the junior doctor like you, pulse volume may be absent. Peripheral coldness, same. Capillary refilling time, same. Blood pressure, whenever you see a low blood pressure, the next option is that you are changing the monitor. That's what we are doing now, because now it's a digital era. So you are changing the monitor. So the second one also low, then you are trying to measure this blood pressure with a manual count. So now we have 3 readings. Which one is correct? I don't know. Again, what I'm trying to say is most of these parameters are subjective, depending on how experienced you are, depending on which country the machine is produced by, whether it's Japan or German or for that matter China. So various things will happen. But only objective parameter you have is urine output. So if you have a catheter, if that catheter is not blocked, if you have 5 ml as a urine output, so that's 5 ml should be 5 ml for me, 5 ml for you, as well as even for the bystander, it should be 5 ml. So that's the only objective parameter that we have. That's why we are going behind this objective parameter. So monitoring urine output is very, very important in dengue. That's what I'm trying to say. So why you are measuring urine output? To get an idea about the tissue perfusion. So if you're having a good urine output, that means renal perfusion is good. So you cannot have isolated good renal perfusion. If your renal perfusion is good, that means your cardiac, your brain, your liver, your other organs perfusion should be good. So basically, if your urine output is good, that means your cardiac output is good. That's the key. So when you are having low urine output, you have to increase the IV fluids. So most of the time what happens is when you are having low urine output, you are giving furosemide. So please don't do that. So low urine output means low intravascular volume, low cardiac output. So if you are giving furosemide during this time, one thing, the kidneys will somehow produce some urine. So already low intravascular volume will be further lowered with this furosemide. So the second thing is I'm wasting about 1 or 2 minutes during this lecture to tell you how important this urine output is. But if you give furosemide, after that, this very important monitoring parameter is lost. If somebody says, Nalin, okay, I had problem with dengue and initially the urine output is low, now I have given some furosemide, now everything is all right. Now urine output is good. Am I happy? No, because I know this is due to furosemide. Now I have lost my very important monitoring parameter. So please don't do that. Whenever you have low urine output, increase IV fluid. Don't give furosemide. It gives you a false security. Right. So we have put the indications for urinary catheterization into the these guidelines. So because this is very important. So all high-risk patients during the critical phase, you need a catheter. Patient with first shock, patient with complications, patients with platelets less than 50,000 needs catheter because these are the high-risk patients. So you have to monitor the urine output very carefully. So all high-risk patient means we are having a 1-year child, below 1-year child, infant, having DHF, you need catheter to monitor the urine output very carefully. Right. So then the plasma leakage in dengue is very, very dynamic process. I'm just going through that. It's very dynamic. So you cannot generalize. So you cannot have a flat rate. So you can't say, okay, my fluid is now maintenance was 5% is 2000. So I have to give this 2000 over 48 hours. So I can give 1000 over half of the time, 1000 over 24 hours. So in that case, I can give 500 ml over 12 hours, 250 ml over 6 hours. That's not the business because it's very, very dynamic. You have to monitor the patient. Depending on the patient's need, you have to adjust the fluid rate. So otherwise, it's very easy, right? So you should not give flat rate. The fluid rate should be decided by patient's clinical condition and natural history of the disease. So I told you, this is the natural history. So you are starting leaking here, gradually leak will go up, maximum leak around 24 hours, then leak will go down, and leak will stop by 48 hours. So you can develop, the patient can develop shock around 24 hours. So if you are matching the leak, this should be your fluid chart. So initially, you need a small amount of fluid. Gradually, leak will go up. So you are matching the leak, your fluid requirement also going up. So maximum amount of fluid is around 24 hours. Then fluid rate should go down. And at the end of 48 hours, the fluid rate should be minimum. So basically, you are simulating the natural history of the disease. So you are having this is the natural history and this is the simulation. So gradually increasing, then it's coming down. So that's what happens. So if the child presents with shock, you have about shock now. So usually shock occurs around 24 hours, you know, somewhere here. So this part has already occurred at home. So you don't have to worry about this part now. So shock usually occurs around 24 hours. So this part has already occurred at home. So now we have to monitor or manage from this point onwards. So on admission, you need huge amount of fluid. So shock management we'll discuss in a minute. So anyway, so we have to manage shock. We have to give huge amount on admission. Then fluid rate should be gradually come down. So if you give the shock, this should be your fluid chart. So you are giving huge amount of fluid somewhere here. Gradually fluid rate should come down. So after 24 hours, fluid rate should be minimum. So on admission, you need huge amount of fluid. Then it should come down. Then after 24 hours, it should be over. So basically, we have to manage about 24 hours. So again, you are simulating the shock. So this is the beginning. This is the on admission. So it's like this. So dengue is very simple disease to manage if you are doing it properly. However, can you manage dengue like this? You are giving very small amount of fluid over 48 hours. No, because dengue is a very dynamic process, dynamic disease. So you cannot manage dengue like this. Right. So what are the fluids that we have to give? So always remember it's isotonic crystalloid for infusions as well as boluses. Nothing else. You are giving normal saline. If you want, you can use the heartburns, but nothing else. It's normal saline, no heartburns. You can give as infusion, you can give as bolus. Then you are using hypertonic colloid. This is only for boluses. So yeah, now you're using hypertonic colloid, the dextran. 40% dextran is the only hypertonic colloid that we are using. So this is as bolus. So you are not using as infusion. So this is a drug. So if you want, give as a bolus. Indications for colloid. So if you're having a shock, you're treating the shock first. After 2 crystalloid boluses, you have to think about colloid. If you're having a shock, already having fluid overload, again think about colloid. If you're having shock, we know you're going towards fluid overload, think about colloid. So these are the indications for colloid. So if you are giving colloid fluid, so this is it should be only during the critical phase, only as boluses, no infusions. So bolus is 10 ml per kilo. Somebody has asked that question during the previous lecture. Yes, so this is one indication to give 10 ml per kilo fluid as a bolus during shock. There are only 4 conditions that you are giving 10 per kilo fluid in shock as bolus. So one is dengue, DKA, neonate, and trauma. So just remember, those are the 4 conditions in shock. We are giving only 10 ml per kilo of fluid due to different reasons. Here, what we are trying to do is that we are worried about the amount of fluid that we are giving during dengue. So you should avoid fluid overload. So if you can manage shock with 10 ml per kilo, you don't have to give 20 ml per kilo. That's a different story. So that doesn't mean that after 10 per kilo, you are just waiting without doing anything. After 10 ml per kilo of fluid, the child is still in shock. So you have to give the second bolus. So that means basically after 10 ml per kilo, you are reassessing the child before giving the second bolus. That's all about it. So bolus is 10 ml per kilo, but after the bolus, we have to reassess to see whether this child needs any more boluses. So maximum 3 boluses in 24 hours. And 6 in 48 hours. So this is about the colloid administration. So only during critical phase, only as boluses, no infusions. Bolus is 10 ml per kilo. Sorry about this. So this is a colloid administration. So I was discussing about the shock management initially. So this is colloid. Anyway, we have to give 10 ml per kilo. Nothing about 20 ml per kilo. Bolus is 10 ml per kilo. So you never give half bolus. There's nothing called half bolus. If you want dextran, give the full bolus. But if you don't want dextran, don't give it. And maximum 3 boluses in 24 hours and 6 in 48 hours. Right. So when the child is not responding to conventional IV fluid treatment, you have to think about these 4 things: acidosis, bleeding, calcium and electrolyte, and sugar. We think it's A, B, C, and S. Acidosis, bleeding. C is calcium and electrolytes. and then sugar. So think about these 4 things. So whenever you are having shock, treat shock first. The shock management is 10 ml per kilo normal saline. You are giving the first bolus. Reassess the child. Still in shock, give the second bolus as 10 ml per kilo normal saline. Reassess the child. If you're having the shock, persistent shock, the third bolus should be dextran. So that's the simple theory about dengue. Right. So then about bleeding. What about bleeding? So bleeding in dengue may be 2 different scenarios. One is overt bleeding. You can see the blood. It may be the hematemesis, melena, some kind of that type of bleeding. You can see the bleeding. So most of the time it's concealed bleeding. You cannot see blood outside. So what we are thinking is this bleeding is in tissue level. So how can you detect this type of bleeding? So management of bleeding, always blood transfusion. You are giving packed cells, no other blood products. That's again a common mistake people are doing. No place for FFP, no place for platelet, no place for anything. So if you see bleeding, if you are suspecting bleeding, management is blood. So these are the indications of blood. If you see significant overt bleeding, you can give blood. And then if you are suspecting the concealed bleeding, in dengue, we know that when the patient is bad, that means it is due to the fluid leaking. So if you're having a fluid leaking, the PCV should be high. So if the patient is bad, PCV should high. So if you're having a very bad clinical condition with low PCV, that's not tallying, that's not compatible. So that's the time that you have to suspect bleeding. So if the child is not improving, but the PCV is low, that is bleeding. So PCV drops without clinical improvement is one indication for bleeding, and shock not responding to crystalloid and Coloid. So I told you shock management, first bolus normal saline 10 ml per kilo, reassess. Second bolus 10 ml per kilo normal saline, reassess. Third bolus should be 10 ml per kilo dextran, reassess. Even after dextran, if the child is not improving, this is the time to give blood. And end-organ dysfunction, despite adequate fluid, again you have to give blood. Early liver failure, you have to give blood. So these are the indications for blood transfusion in dengue. How to give blood? It's always packed cells. You are using 5 ml per kilo, no 3, no 5, no 3, no 10. It should be 5 ml per kilo or 1 hour. So usually 5 ml per kilo packed cells will increase your hematocrit by 5 points. So that is also important because now see, initially your PCV is now 35. You decided to give blood. Now we have given blood. After the blood transfusion, now the PCV we are giving 5 ml per kilo blood. So your PCV is now 55. So can that happen? Yes. If that happens, can this be due to the blood transfusion? No. We know with 5 ml per kilo blood, the PCV should go up by 5. So 35 should be 40. If PCV is 55, that means you are having leaking, significant leaking in addition. So this is leaking plus bleeding. So definitely you need to increase the fluid also. Then hypocalcaemia. So it's common cause for a conversion in dengue. So you are using empirical calcium in complicated DHF or deteriorating DHF. Again, not for all. So we have seen even a little bit, even a very the early stage of dengue. Some people are using oral calcium. So that's not the key. If you're having a low calcium, that's a different story. But empirical calcium is needed only for complicated DHF and deteriorating DHF, not for all. So dose is 10 ml per kilo, 10 ml, 10% calcium gluconate, 1 ml per kilo. 10 ml is the maximum. You have dilute in equal amount of normal saline. You can give it over 1 hour. So 6 hourly we are going to give this. And hyponatremia, so again, is a common condition. Cause of conversion in dengue can cause cerebral edema and coning. And so that is one reason that you should use only isotonic fluids in DHF. So no place for N/2, no place for hyponatremic solutions in dengue. So this is my natural history. You have seen this slide again and again now. This should be the fluid management ideal. If the child presents with shock, this should be the fluid management ideal. But most of the time, we are seeing this type of fluid charts in our ICU. Then I thought I have to think about why this is happening. What is the reason for this type of fluid shock? So you are giving only 2 ml per kilo of fluid because some people believe that you should give very minimum amount of fluid during the critical phase. So you're giving only 2 ml per kilo of fluid. All of a sudden, you need a bolus. What does that mean? The child develops shock. You need a bolus. What is the reason for this shock? Inadequate fluid. So after the fluid bolus, child is improving. Now urine output is good, capillary refill time is now improving, and clinical condition is improving. You think that you have done a marvelous job and you are cutting down fluid. You're going back to the 2. So this is not rational at all because this 2 ml is not enough. That is why this patient is entering, this patient is developing shock. So the reason for this shock is inadequate tissue, inadequate fluid. So now after the bolus, at least after the bolus, you have to increase the amount of fluid. So you are continuing the same thing. After 2-3 hours, second shock, then you are giving dextran. Again, do the same thing. After 2-3 hours, again shock. Now the normal saline, blood, and MIC. This is what happens usually. Please don't do that. So that's why I'm telling management of dengue is not try to give minimum amount of fluid. It is not somehow try to give maintenance, try to give only maintenance plus 5% fluid during critical phase. It is maintaining the hemodynamics, but with minimum amount of fluid. We are very happy to see this type of fluid charts. So initially small amount of fluid, gradually increasing, and in the middle, you are giving huge amount of fluid, then gradually you have to come down. So this is one of the child that we have managed. This is the ICU. So I don't know if that you can see. This child is having a PT tube, 2 IC tubes, 2 PD catheters. So respiratory failure, renal failure, and 2 organ involvement with respiratory failure. The outcome will be, the recovery may be available. We know they are going to die, but we are trying our best to do everything possible. So we want to avoid this type of situations. So very briefly, two cases. So this one is 40 kilos child admitted to district hospital on day 2 of fever. NS1 was positive. First shock detected on day 4. Child had melena and tongue-side bleeding. Transfer to LRH on latter part of day 4. So this is how they have managed. Normal saline in 5% dextrose, 2 ml per kilo over 11 hours, 2.5 ml per 9 hours. Dextran, so-called half boluses 3, and dextran full bolus 1. So I have put this into the chart. This is what has happened. Look at this, a very small amount of fluid. You can see that the PCV was happening 37, 48, 47, 50. And look at the urine output 1.1, 0.6, 1, 0.4, 0.4, no, 0.3, 0.4. And the heart rate, you can see 150, 130, 137. So pulse rate is high. So you are giving small amount of fluid. PCV is going up. Urine output is coming down. You don't have a big brain to understand that this fluid is not enough. So they are giving half bolus dextran here. Again, coming back to the 2 ml per kilo. Half bolus dextran again. Coming back to 2 ml per kilo again. So now I have told you. So if you're having more than 4 hours untreated shock, outcome is very, very poor. So shock means if you calculate for the urine output, less than 0.5. We want at least 0.5 ml per kilo urine. So 1, 2, 3, 4, 5. 5 hours shock, outcome is very, very poor. So not catheterize, not match the leak, ignore the pulse rate, urine output and the urine output and pulse. So this is what happens. So this is what happens on admission. Saturation was 85, dyspneic, periphery is cold, tachycardic, blood pressure low, PCV is 42. We try our maximum. So we'll look at this. SGPT on initially it was 67, goes to 7,000. Or COT 41 goes to 28,000. So this child died with liver failure after about 2 weeks. Another child, 5 years. This one was directly admitted to the ICU because this son's mother is a dermatologist. So we have managed like this. So we were given 3 ml per kilo of fluid, but we are monitoring on the parameters. You can see the urine output 1.8, 1.5, 1.2, 0.75, 0.71. So now you can see, initially you are given 3 ml per kilo fluid. Child is producing 1.8 urine. Now, with the same amount of fluid, the child is producing only 0.71. So again, you don't have to wait to this magical mark of 0.5 ml per kg per hour. So we thought the fluid is not enough, so we have increased it to 5. But after starting 5, 1.2, 2.6. Now you can see this 5 is maybe a little bit more because now the child is producing more urine. So we can come down to 4. Even with 4, 1.4, 1.7, 1.8. So we try to come down with a 3, again 0.9. So by doing this, now we know that this child's leaking is between 3 and 4. So it's very simple. So we have gone up to 4. So manage like this. And child needed the blood, dextran, another blood transfusion. So depending on the clinical context. And then look at this. HGPT 49 to 103, SGO 210 to 225. So this child went wrong. So now I am telling the difference between the death and the survival in dengue hemorrhagic fever is urine output. If you have a good urine output without furosemide, you can go home. If you don't have urine output, then you may die. So common pitfalls: not simulating the natural cause of the disease, try to give minimum amount of fluid, cutting down fluid just after bolus, not try to prevent shock, not giving blood early, not sending the child to ICU early. So if you want ICU, send to the ICU early because we are doing intensive care, not the fulminant care. So take home messages: minimum fluid in febrile phase, just sufficient fluid in critical phase, minimum fluid in recovery phase. Please don't give unnecessary boluses. By doing that, we can treat shock, avoid organ damage. We can prevent fluid overload also. As I told you, these are the two main causes for death in dengue. So if you are preventing both, child should go home. So we want this type of patients. So thank you very much. So I'm trying to answer some of the questions. The child is presented with uncomplicated shock. After giving 20 ml per bolus, the child comes to compensate shock. Then how much can we give 10 ml per kilo fluid? So I think I have answered that question. So in dengue, what we have to do is first bolus, if the child is in shock, compensated or uncompensated. The child is in shock, 10 ml per kilo as a bolus. Then reassess. If the child is still in shock, second bolus 10 ml per kilo. If the child is still in shock, after second bolus, give dextran. So even after giving dextran, if the child is in shock, think about A, B, C, and S. To suspect bleeding, how much PCV should be reduced? So there's no magic number. What you have to do is, you are suspecting. I told you now when the patient's clinical condition is not good, we are thinking that the PCV should be high. So if the child is having low PCV with poor circulation and poor the condition is not improving, then you have to suspect bleeding. Other than dextran, what are other colloids can we give if the patient is leaking? So nowadays we are using only dextran. Earlier we were using hydroxyl ethyl starch, we call it HETA starch. Now, please don't use it. There are so many problems. So I'm not going to go into detail because lack of time. So remember, in dengue, Coloid is 10 the dextran. Dextran dose should be 10 ml per kilo. So bolus, as a bolus you have to give. So no other colloids. Think about dextran. There are so many reasons. If a patient comes with DHF pleural effusion, can we give dextran 40 initially? So any DHF patient, to say it's a DHF, you need fluid leaking. We know the fluid leaking in dengue is accumulated in mainly in two places, pleural space and peritoneal space. Invariably, if your child is having DHF, they will have pleural effusion and ascites. So that itself is not an indication to give dextran. So as I told you, those are the indications of dextran are shock, not shock after two crystalloid pulses. Then if you think the child is in fluid overload, because now especially for us in ICU, we know that we are getting patient who are managed by the other people. So then sometimes on admission itself they are on fluid overload, still in shock. Then you can't give more fluid. So then you can give dextran. So just because of pleural effusion is not an indication for dextran. So should we calculate minimum fluid in febrile and recovery phase? If not, how do we advise patient on fluid intake? So what should happen is the children are not taking more fluids, even you ask. So you can ask the patient to get liberal fluids without anything. Don't force the child to take fluid, but whatever the amount the child can take, you can take. So that's the minimum amount. So you're not going to huge amount. You are not going to give if you are giving IV fluid, if the child is vomiting and if the child is not taking orally, then you can do about 2 ml per kilo of fluid. But other than that, if the child is tolerating oral, allow them to take whatever the necessary. As you said, if patient present to hospital at the high rate of leaking, 24 hours after starting leaks, do we give only half of the maintenance plus 5% dose? Again, so don't go by these arbitrary numbers. So what is important is the child is at home for 24 hours. So you have to start with a huge amount of fluid because the child can go into shock. So then gradually you can come down on the fluid depending on the hemodynamics. Don't think about this arbitrary number. Just so ideally you should manage with half of this fluid. But at the same time, if the child has not taken any fluid during the first 24 hours, so for the treatment of shock, you may have to use huge amount of fluid. So that's this. Don't go by this arbitrary number. Always respect the patient's clinical condition. Then the problems are very minimal. How do you calculate ideal body weight if using H+4+2 formula, or does the formula changes with the age? So go by the Holiday and Sega method. So usually first 10 kilos 4 ml per kilo, second 10 kilos 2 ml per kilo, after that 1 ml per kilo. That's how you calculate the ideal body weight. Yes, ideal body weight should be calculated with the ideally by the chart. So we have a height chart. So go to your PNF or all the boards, pediatric boards are having this chart. So go by the height. If the child develops shock during leaking phase, do we need to reduce the resuscitated fluid from total fluid quota? Again, so don't go by this quota because that's the main problem. So quota is just for the take some idea. You may manage this patient below quota or above quota. That doesn't mean. So, but when you are giving fluid bolus, you are treating the shock. So after the shock management, the amount of fluid should depend on the patient's clinical condition. So I'm not trying to give only the quota because if the child develops shock or if the child's clinical condition is not good, we have to give more and more fluid. Frequency of full blood count to check for entry into critical phase. So usually, usually what should happen is until the full blood count is 50%, full blood count is 150. Until about platelet count is 150, you can do daily counts. If they are below 150, you can do BD counts. And if the child is having below 100,000, usually you need about 670 PCV and twice a day count. For leakage, can we detect by gallbladder thickening? Yes, and the leakage, you can detect leakage with various means. So you can do ultrasound scan and detect as somebody has mentioned. But ideally, you don't need ultrasound scan to detect leakage. So if you are with the patient, if you know what is happening, I have shown you how to detect it. So you can do it. Yes, if you have the ultrasound facility, you can do it. But that's not the indication to do 4-hourly ultrasound scan just to detect leakage. If NS are negative, how we identify the secondary dengue episode? So if the NS are negative, if the platelet count is less than 150,000, so anyway you have to manage like dengue. So if the child develop the platelet less than 100,000, that means the child is entering the critical phase. So you have to manage like DHF. is NS1 positivity specific for dengue? Yes, NS1 positivity is specific for dengue, but there are some cross reaction with the COVID also. But don't think about these small things. So NS1 positive, unless proven otherwise, that is dengue. Is there any rough amount of IV fluid that we could increase with reducing urine output? Is there any rough amount of IV fluid that we should increase with reducing urine output? The thing is now, if you are monitoring the patient, you should not have 0.1 ml per hour urine output because it will not happen or suddenly, right? So as I shown you, the proper management, proper monitoring, the urine output is gradually coming down. So it will not happen 5 ml per kg in first hour, then second 0.1. So that should not happen. If you're having 0.1 urine, that means the child probably in shock. So you will assess the child. You will see that other parameters. So depending on the parameters, you are deciding. Just because you are having 0.1 ml urine, it may be several things. Your catheter may be blocked. The child may be in shock. So you should know what is the reason. So then you can decide. So if the child is in shock, we know how to manage it. Right. So how much pint of blood we can give? So again, I told you it's 5 ml per kilo. Blood, the dose is 5 ml per kilo. You have to give 5 ml per kilo 1 hour if the child needs that. Right. We stop that. So next is 20 minutes lunch break. So we can go to lunch and come back in 20 minutes. Thank you.